this in the future. So thanks so much for that. Can I just move that slide forward just to talk a little bit about the collaborative? So for those colleagues who have not been on the Masterclass series before, this is a collaborative between 5 organisations, my own organisation, which is Northwest Association of Directors of Adult Social Care, but we've also got MIAA, AQUA, Northwest Leadership Academy for the NHS, and Northwest Employers. So we work collaboratively together to bring these series of masterclasses to you all, and hopefully you find them useful. At the end, we will be asking you to give us some feedback on how this session went, and then what you might want to see in the future in these masterclasses as well. So thanks very much for that. So if we could just go on to the agenda. Again, if you could just mute yourselves, please, colleagues, that would be really helpful. Could I just, I'm going to bring forward a couple of colleagues just to introduce themselves really. So we've got Carrie, we've also got Sarah and Dan, and then also Jack and Daniel. So can I start with Carrie? Do you want to introduce yourself, Carrie?
Yes, thank you very much, Helen. So my name's Carrie Phillips. I'm the programme leader for the Masters of Social Work at the University of Sunderland, but I'm also a PhD student looking at hospital social work, and I'll tell you a little bit more about my background when we get to my bit.
Okay, is Sarah and Dan on the call?
Hi, yeah, I'm Sarah Lee Bergin. I'm a locality manager for short-term services, which supports the 2 hospitals, predominantly in Cheshire East as well as some out of areas, and I'm a social worker by background.
That's Sarah. Is Dan with you as well?
He should be joining us. I know he was just finishing his last call, so he will be here. Dan will be joining me to support during our section.
Okay, brilliant. And Jack and Daniel, it's got 2 Daniels and Dans here. Might get confusing. Jack and Daniel?
Yeah, morning everyone. Jack Fallows from the Northern Care Alliance, part of the quality improvement team that led on the Days Kept Away from Home collaborative.
Yeah. And is Daniel with you?
Yeah, I'm here, Helen. Hi everyone. My name's Daniel, also from the QI team in the Northern Care Alliance.
Okay, you're breaking up a little bit, Daniel. Hopefully that will be sorted out by the time we get to your presentation. So thanks so much for that. So yeah, in this session we are going to be reviewing the role of the social worker in hospital discharge. We're going to be looking at data as well, so hopefully if those data geeks that are on the call, you might find that really useful. We're looking at the contribution of social work to effective discharge, so hopefully it's going to be a really great session. As I say, we will be doing a little bit of breakout. It's not too much actually towards the end, for you to sort of come together to ask maybe a panel some questions that you might want to get some insight into. So can we start then, Carrie? Can I hand over the floor to you? And I think you're going to be using your own slide deck to go through. Is that right?
Yes, thank you very much. Is that sharing my slides now?
Not yet.
Oh,
not yet. You just want to take it off me.
I think you might need to stop sharing, Christina, and then I can press share.
Okay, I've stopped sharing, Carrie, so hopefully you can pick it up. If you're having trouble there, I can always bring them back up again.
We can see the slides now.
Yeah. Fantastic. Okay. Yeah, so first of all, thank you.
So sorry, Carrie, I can't see them, so I don't know if that's just me and other colleagues.
I can see them.
I can see them.
Yep, I can see
I
them.
can see.
Yep.
Right, okay.
Sorry,
it's
Helen.
a bit tricky that the chair can't see them.
I'll try
go?
one more time. Is that working, Helen?
No, but you carry on. I've got the slide pack anyway, so I can just make sure I can see them on my own slide pack.
Fantastic. Okay, So yes, first of all, thank you very much for to Christina particularly and Helen for inviting me today. So as I said, my name's Carrie Phillips. I work at the University of Sunderland. And I have very, very nearly completed a PhD study looking at hospital social work, and that's what I'm going to talk about, the key findings from that today. You can't tell from my accent, but you've got a lovely picture of Preston Royal Hospital because that's where I'm from. So it's pretty exciting to be talking to so many colleagues from the Northwest, even though I'm currently based in the Northeast. So I'll just talk very briefly about the sort of rationale behind my study. So before I joined the university, I was a social worker in various, I would call them health-related roles. So working in neurological rehabilitation, for example, working with NHS continuing healthcare, lots of roles where there was a lot of overlap between the social work role and the NHS and hospital role. And so the aim of my research was to investigate the relationships between the structures of the NHS and local authorities and the practice of individual social workers. How do those structures that govern two quite different organisations interact with each other to impact on what social workers actually do? And the point of this, and the reason why I'm so pleased to be here, is to inform the training of hospital social workers. So students, current social workers, leaders in this area. I need to explain my little doodle because this is the key reason why I became interested in the issue of social work and hospital and how the two interact. So this is my pretty terrible sketch of an ID badge that I had when I was in practice. And what I'd noticed was that hospital staff had a white ID badge that had their role, their picture, access code embedded in it, everything you'd expect from an ID card. Contractors, so people coming to fix you know, the radiography equipment or maintenance of the building, anything like that, had a bright yellow badge. And what I noticed was that social work was, as far as I could tell, the only profession that had a white badge with this bright yellow stripe down the middle. And I became really interested in this idea that, okay, we've got a badge, we can get in places, we belong in the hospital setting, but there was a very clear visual marker that we weren't NHS employees and that we were somehow outside of that organisation and different from the NHS and the hospital. And I started to wonder how that impacted on our practice. So hospital social work is something that there's been a little bit of research around already. We know that social workers, particularly in England, my study takes in the whole of the UK, but I'm going to talk about England specifically today, that social workers usually are employed by a local authority, but they work into and support the operation of acute NHS hospitals. And we know that discharge planning is one of the key roles, if not the key role, that social workers undertake within the hospital. And previous research has highlighted that the value of social work in protecting the human rights of patients, of promoting social work values around autonomy, inclusion, choice, you know, really focusing on the individual and what they need. And that generally there's a very positive interaction between individual social workers and individual, I've called them sort of clinical staff. So nurses, occupational therapists, physiotherapists, and of course the doctors on the ward. But there can be some significant difficulties negotiating those gaps between health and social care at an organisational level. And I'm sure we're all aware of, you know, kind of media narratives, political narratives that kind of position NHS care as implicitly more important than social care, even though the two need each other to function adequately or effectively. So the first thing I did was look at how many hospital social workers are there across the UK, because when I started, we didn't have any figures for that. And you can see that actually across the UK, the picture looks very different depending on where you are. So the light blue is areas that don't have a social work team, right through to purple. I tried to make it like a weather map, but the purple is areas that have a very large social work team. And as far as we can make out, the areas with larger teams tend to be areas that have a larger older population, tend to be larger local authority areas, as you'd expect. But there are some anomalies. And what I thought might be interesting and useful for the people on this call is to zoom in a bit and look at the northwest region. So again, we can see there's some variations. Some areas such as Rochdale, this is from Freedom of Information requests, don't have a hospital social work team, like a dedicated team employed by the local authority, whereas areas such as Lancashire and Cheshire East have quite a large team in that area. This data needs to be taken a little bit skeptically, because Freedom of Information requests are only as good as the people who answer your question, and that could vary between, you know, the hospital social work manager or somebody who is an information governance manager. So yeah, but as far as we can tell, this is the picture across the UK and in the Northwest specifically. So in terms of the number of qualified social workers, again, the Northwest has a very typical picture in terms of the majority being employed by local authorities. The NHS tends to have a few social workers, often in more specialist roles. But what was also interesting was the number of practitioners, social care practitioners in social work teams that aren't qualified social workers. They have various names: social care assessors, wellbeing officers, but generally people who will provide assessments under the Care Act, may assess mental capacity, but don't hold a recognised social work qualification. These figures are from 2022. And since I gathered these figures, Social Work England published their figures about hospital social workers. And their figures are from slightly earlier, they're from 2020, and they show a larger number of hospital social workers, which leads me to believe, you know, as I've said, no figures are absolutely perfect, but there seems to be a trend away from having social workers based in acute hospitals or associated closely with acute hospitals. And in fact, there may be as much as a 15% decrease in the number of hospital social workers over those 2 years, which to me seems, you know, a somewhat of a cause for concern, depending on where those workers have gone, what they're doing, how hospital discharge is now being supported. So another thing that I looked at, quite apart from whether there's a dedicated social work team or not, is whether the teams have accommodation within a local authority, within the hospital that they support. And this picture is quite similar to the picture across the UK, in that the majority of teams have a office within the hospital they support, but a significant minority don't. And what I found was that impacted on the how social workers perceive the quality of the work that they could do. So if they were not based in the hospital they support, they had more difficulties accessing the wards. They had more difficulty accessing information from hospital staff. It was significantly more difficult to build those working relationships and gather useful information about the patients by telephone than it was to pop up to the ward, familiar faces, building that trusting working relationship with the staff. But also really significantly, it was more difficult for them to spend time with the individuals on the ward, talking to them about, their wishes, their aspirations, their home conditions, everything you need to build a good strengths-based social work assessment. And some of my participants really worried about that. They worried that particularly when it comes to assessing mental capacity, good practice might be to revisit the discussion, the conversation, that decision with the person on more than one occasion. But they were being forced by circumstance to do a lot of that work over the telephone or in a one-off visit rather than a repeated, again, building that relationship with the individual. And the message that I got both from freedom of information requests and from my participants who I interviewed or who filled in a survey was that COVID-19 restrictions were a big driver of that, that it seemed pragmatic, sensible to move non-essential, when I say non-essential for hands-on care, personnel out of the hospital during lockdown restrictions. But in a lot of cases, that trend has not reversed. So teams have been very slow to get back into the hospital, or in some cases haven't been able to at all. And this response from Trafford Borough Council is fairly typical of that description. So they told me that staff previously based on hospital sites are now pooled with the community. There's a move towards discharge to assess models, so making long-term decisions about a patient's care after they're deemed medically stable and after they've moved out of the hospital ward. But they do have some staff based on acute sites to support complex discharges and to support safeguarding inquiries. Again, really key roles that social workers have. So if we have this trend of social workers being moved out of hospitals, is that a problem? Why do we need them? Why did I say that's a potential concern? So one of the metaphors that comes up a lot in research into hospital social work is this idea that social workers form bridges, links. They span gaps in knowledge. So thinking about the knowledge of resources in the community, what's available to people when they're discharged. Also communication, so supporting patients and clinicians to communicate effectively, and crucially to sometimes support communication between patients and families. So a common concern that social workers had was around families pushing their own views about what the person needed and what they wanted that maybe conflicted with what the person wanted for themselves. And social workers were skilled in negotiating that and explaining, the idea of mental capacity, the idea that people who are able to make decisions for themselves must be able to make decisions for themselves, that families don't have a right to override those wishes. But also, even where a person lacks capacity to make that decision for themselves, the decisions have to be made in their best interest, that there isn't a proxy decision maker, and that while family views are extremely important in that scenario, they're not the be all and end all, and that we need to focus on the individual and what's best for them. And the final thing that my research has looked at that kind of hasn't really been explored as much elsewhere is the idea that social workers form what I've called a temporal bridge, so a bridge in time. So they don't just think about the individual as they are now in the hospital bed. They think about that person's life history. How have they come to be here? What has led to their, what immediate circumstances have led to their admission, but also what are their traumas, what are their social supports, how have they built up to become the person that they are today. But also what social workers felt was unique to their role was really focusing on the future. So thinking about what is life going to look like for this individual once they're discharged from hospital. And you know, my research is limited by the fact that it was just social workers that I spoke to. But they felt that this was different to clinicians who are looking at what can we do, what do we need to do to fix the acute problem and get this person out of hospital. Social workers felt they had a longer term view about the future and what, what that might look like for that person. So looking at a few quotes that illustrate these bridges in a bit more detail, and these are all quotes from participants from the Northwest. And like I say, these patterns were very similar across the UK, but just to, provide a bit more of a local flavour, I guess. But one social worker who I'll call Pippa said, I need to be courageous to challenge back to the medics and other clinicians who would push for faster discharges. For example, comments such as, we need to arrange a best interest decision for this patient to go into 24-hour care when the patient had not had capacity assessed. Or every time capacity was in question, assuming that a social worker was needed to complete the assessment, even if the decision does not involve social work. For example, decisions around medical treatment or therapies making equipment provision. So what Pippa was saying, in common with a lot of participants, was that mental capacity is a very strong example of this specialist knowledge that social workers have, that despite the legislation and despite years of training around it, there was some staff on the wards that would make assumptions about a person based on their diagnosis, for example, dementia, or based on their presentation on the ward, without stopping to think about, okay, is the fact of them being in the hospital making them more confused? Is there a better way to give this information that would help them understand the choices that they have to make? And they very much saw that as the social work role to facilitate that and to provide that check that these best interest decisions, these mental capacity assessments have been done in the best possible way. I've got an example from a participant I call Ash, who's a local authority social worker, who said, I genuinely enjoy working in the hospital team once you've been able to build a rapport with staff. We as an MDT can work on some really good positive outcomes for patients and families. So this was very much a theme throughout the work as well, was that social workers really enjoyed and valued the work that they did. But obviously they did talk about challenges as well. And Ash went on to say, COVID has had a significant impact on these relationships. And also during that time, Care Act assessments were shortened, additional funding was in place to facilitate discharges. This has now ended and health still expect that we can complete shorter assessments and have additional funding available. They were also able to utilise a no choice policy. So the idea that somebody couldn't necessarily choose the care that they had or the residential placement they went to because of the risk and the need to get people out of hospital as quickly as possible. This now leads to some debates when we have to advise ward staff that patients do have a choice where they go on discharge, especially if they're paying for it. And this resonates very much with the brilliant podcast. I think it was the participants from Wigan who were talking about sort of the legacy of Care Act easements, the fact that whilst, again, these were pragmatic and sensible at the time, they've led to some lasting misunderstandings or expectations or difficulties with the work. The other thing that came out quite strongly was about frustration. So this idea that sometimes clinicians will prescribe social care. They'll say to a patient or a family, you need residential care or you need 4 calls a day. And social workers felt that this represented really an undervaluing of the skill and the knowledge that they bring to a social care assessment. And they talked about the fact that very often, somebody had been told that they needed residential care or 4 care calls a day. And when the social worker went and talked to them about strengths, potentials, resources, family support, actually that person needed much less than that they could go home, that maybe they needed just 1 or 2 calls a day, and they felt that there was a risk adverse and a undervaluing of that skill that led to clinicians, I guess the feeling was overstepping their boundaries sometimes. One participant quite memorably said, well, I would never prescribe a medication because I don't know about that kind of thing. So why is somebody trying to, I guess, undermine my job sometimes? Return to the idea of communication, so communication bridges. So Tori, another local authority social worker, said, hospital work is fast-paced, as you have to get people discharged quickly but safely. It can be a rewarding experience. It does include a lot of multi-professional working, so it's really important that relationships are good with health colleagues. This isn't always the case, though, due to the pressure of beds, and you have to be strong and confident enough to put your point across if you think what they are asking is a possible unsafe discharge, and tell them the discharge won't be going ahead. So again, thinking about how important it is for social workers to protect the rights, protect the safety of patients, and really to have those good working relationships where professional challenge is on the table, where it feels okay, and it feels that other people will be receptive, sometimes if there's disagreement within that multidisciplinary team. And really a feeling that disagreement, or the ability to disagree, is actually the sign of a really strong team, that it doesn't cause conflict or resentment, but that it's an open dialogue about what's best for the individual patient. And finally, this idea of time. So Jessie, a former NHS manager, said that discharge is quite, I find this very memorable, evocative quote, but discharge is a conveyor belt of stack, pack and rack of people. There's no choice or control, and it's all about key performance indicators and not person-centred. Ward staff want everyone discharged into 24-hour care, as opposed to what the person wants to happen and can be supported to do. And for me, this really sums up the value of social work in hospital discharge, in focusing very much on what the person wants, but also, again, thinking about this strengths-based approach, what they can be supported to do, what's going to be possible, what does the future look like for this person if we can put support in place for them. Finally, there was some talk about the future of hospital discharge. As I've said, there's some figures that suggest that social work is being moved out of hospitals. There is a move towards discharge to assess models. And the general feeling from participants was that discharge to assess models are a good idea, that hospital is not the right place to be making complex, long-term and really high impact decisions about a person's care, about their residents, about their future. But, and it was a very significant but, that those models need to be properly resourced and they need to have social work involvement. It's really important that social workers are not divorced from the whole process of discharge, about thinking about mental capacity, thinking about strengths, thinking about family networks. And also there was some caution, I guess, about the potential for discharge to assess models to just move the problem down the road. So whilst a lot of the focus and the pressure of hospital social work can be about discharging people from a hospital ward, how is it any better if we're just having that pressure discharging people from bed-based rehabilitation? It just moves the costs, the pressures, the stresses to a different part of the system, rather than solving them. So that's one of the thoughts that I think, you know, I would encourage you to think about when we have our breakout session and when we've heard from our other participants, is about how do we make sure that the trend is towards discharge to assess, and that's probably a good thing. But how do we make sure that it's wholly a good thing, and that it doesn't miss the key elements of good social work that contribute towards effective, safe, and the best possible discharges for individuals. Thank you very much for listening. I've put some references up here, and particularly I would point you towards a research report that I was fortunate enough to work with the British Association of Social Workers, BASWA, to publish, which basically talks about the same things I've just talked about in a little bit more detail and makes some recommendations for policy and for practice when it comes to hospital social work. Thank you ever so much, everybody.
Thanks so much, Carrie. That was really, really helpful. We have got a few minutes, and thank you for sharing those resources as well. And again, just to colleagues on the call, that all that will be available for people to have a look at a later date. And thank you also for mentioning our podcast series as well, which we'll get onto probably at the end of the session, which North West ADAS has done a series around hospital discharge, and have got some colleagues that are on the call as well that were involved in that podcast series. So thanks for that. Because we've got a few minutes, there was a couple of comments in the chat just to say that Rochdale and Wirral have just highlighted they have actually got dedicated teams. So that's great. I don't know if they're new. So I don't know if our colleagues from Rochdale and Wirral could just say a little bit about that, whether they're relatively new.
And yeah, like I said, Helen, it's the problem with freedom of information requests is they're only as good as the people who answer you.
Yeah.
So I know for a fact, obviously, I know some of the teams in the Northeast, and I know for a fact that the figures I got for them were slightly incorrect. So okay. I'm happy to be corrected.
So Tina, I think you put something in the chat and you've got your hand up. Did you want to come in?
It was just to say we've been running for 2 years.
2 years.
I'll put it on the chat though. So
yeah, thanks very much. And I think also there was a question from Anita about trends around complaints. So I don't know if Anita wants to come in and ask that question directly to Carrie.
Oh, hi, sorry, I'm just putting my camera on. 1 minute. Hi. No, it was just, I know a lot of them are from the social work team, a lot of the people on the calls, but it was just wondering, based on what you were saying, Carrie, are you seeing kind of like a correlation and a trend? You know, if you haven't got that support communication network, because what I'm finding, I know I'm from a different area, as in CHC, now AACC, all adult continuing care, but kind of the families are going through a process, and whether I should say this rightly or wrongly, but by the time it reaches the team I'm on, they're saying, maybe because it's a difficult situation and they're stressed, but they're saying that they don't know what the process is, they don't understand the process or funding, or they don't understand. They may be looking at nursing homes and it's different types. You know, we would only place in general nursing or EMI, unlike our social work colleagues who may use RESMO. So it's things like that we're seeing, but to me it's so frustrating because it's at the end, if you like, that should happen before it reaches us, you know. So yeah, that's why I was asking that question. Thank you.
Did you want to come back in, Carrie, and respond?
Yeah, I mean, it's not something that I specifically looked at, but I do think that's a really interesting question about whether this trend has changed, you know, how people feel about the process. But I absolutely hear what you're saying, and I think that's one of the biggest risks of moving social work out of hospitals, is the fact that, you know, giving these messages early on and helping people to understand what is quite frankly a really complex process of health and social care is vital. And also one of the big things that's coming out of other research, so I've referenced Paul Willis and colleagues who are, well, they're finished now, but they were doing the Social Work with Older People project, looking at what's important for social workers working with older people, obviously massive crossover with hospital social work. And one of their key findings was that continuity is one of the biggest issues, I guess. If there isn't that continuity, people get slightly different messages or messages aren't passed on, and therefore it makes it even more difficult to negotiate the health and social care system. You don't have somebody sort of holding your hand throughout.
Yeah, and all areas are different, aren't they? All places as we are now are all different. Yeah, thank you.
Thanks, Gary. We've got somebody else with a hand up. Is it Leonie? Got your hand up? Is that right? Forgot that right?
Apologies, it's pressed on my mic. I'm sorry.
Okay. Any further sort of questions for Carrie before we move on? Right, I can't see any hands going up. So once again, Carrie, thanks so much. And obviously, we've got a panel discussion at the end. So hopefully people in the discussion groups can come back with some questions for you later on. So thanks so much. But if we can move on to Sarah and Dan from Cheshire East.
Hi there, you okay? I'll get my presentation up and then start to talk through.
Thanks, Sarah. I feel like I've bonded with you, Sarah, because we've done a whole podcast together, haven't we? Both you and Dan, which was wonderful. I recommend it to everybody.
So I'm not going to be able to see yourselves very well because I've got the presentation up on the screen now. So obviously, if I need to stop at any point, just let us know. What I'm going to go through is probably a common experience of many of our local authorities and hospitals. So I'm not trying to teach anyone to suck eggs or to tell you what you already know, but it's about our experience and things that have worked well for ourselves and also where some of the challenges are and what we're still working through. And for that reason, I call it like the evolution of our role, because it's one of those things that is changing and some bits are definitely moving forward and other things we're having to relook at and adapt as we move forward and find actually some unintended consequences to some of those changes. So I felt a bit like Carrie was talking about, we've had a journey from pre-COVID up to now, and I thought it was worth us referencing some of that and acknowledging some of the difficulties that's brought, but also some of the real positives. So prior to COVID, we had a team of social workers and social care assessors. We've got a mixture of qualified and unqualified staff, along with operational managers, and they were on site at both our hospitals within Cheshire East. Our size of our team hasn't changed dramatically since this time. We've strengthened it and been able to recruit some more permanent workers, because we did have a period of time where we were struggling to retain experienced work in hospital settings, and that's improved. But just for context, really, our team size is very similar. So at that time when we were based on site, it was very much an assess to discharge model. We didn't really know any other way, if I'm really honest. This COVID process hadn't hit us, and we were starting to talk about how we could adopt the discharge to assess model, but that hadn't been embedded or really evolved at that point. We found integration that was there were some absolutely positives to being on site. I've worked in teams where we've been so truly integrated and very much aware of each other's disciplines and been able to complement each other and almost preempt things to kind of support one another rather than taking over roles, being able to very much help each other plan things and go with knowing what we're likely to be experiencing and going through when we're meeting that person. We can anticipate some of the stuff we might need to take. So it was very positive. On the contrast, I've had teams where they felt very much just a part of being in the office, not really part of the team, felt like they are just an extra in the office and not valued in the same way. So it does come down to a degree, the whole team and what their approach is and how they feel we should be doing it, because that was two hospital teams, both in Cheshire, that felt very, very different. And there were obviously pockets within those teams which felt differently, but that was generally the feeling that one team felt very, very integrated, very well supported, and the other team just an extra. We then obviously had COVID, and at that point we were forced partly to obviously step back and to come off site. But alongside that, we also found that one of our buildings was knocked down, and that almost made the off-site working a little bit more longer term permanent, let's say. When we moved off-site, I think it's fair to say for health and social care, we were having to just go ahead and do the best we could in what was an incredibly difficult time for the country, the world. You know, COVID hit us in a way that we weren't really prepared for or experienced. None of us have been in that situation of a pandemic before, where we were suddenly having to do things completely different and having to hand over roles to each other that we'd not done before and work very differently. And that very much felt, I think, scary, if I'm really honest, to the social workers, and probably to help as well, because suddenly we were asking them to support things that we would always do. We were then stepping back and waiting for those things to happen and having to trust those things. And it wasn't about so much not trusting, but we do things differently when we've got different professional qualifications and experience, and just it's a different approach, isn't it? It's why it's so good when all of us complement each other. So during the pandemic, those roles became blurred. We were trying to support that discharge assess model as best we could, and we just needed to support as many people to be safely discharged from hospital in order to literally save lives, wasn't it? We couldn't have people in beds where there were being, more and more people becoming seriously unwell. It was just a really scary time. Alongside that, some staff started to feel frustrated, questioning what their role was in this system, whether they actually needed to be in it, whether they had value if other staff could do it for them. What was the point of all them, that years of experience and qualifications? There were some positives around the fact we did support a lot more discharges safely, and to an extent the discharge to assess model has some real positives, probably not in the middle of a pandemic, if I'm really honest, but the being able to assess people very proportionately, support them to be moved on to the next step of their journey before determining that long-term plan and assess them in the right environment has so many positives. But it did lead to overcommissioning of packages, and we found that placements were prolonged. A lot of people, unfortunately, didn't leave those placements, and that became their long-term placement. We missed the window, and that was partly due to the volume of people that were being supported outside of hospital, but also market failure that we experienced, not being able to commission the care that we previously were able to before COVID hit. So it was a real mixed feeling. With the move to discharge to assess happening, we did find obviously our work moved off site, so we didn't need to be on site as much anyway. We were happy to do a lot more things in the community, whereas we would have assessed people in hospital, then done a review. Our first assessment was suddenly in the care home or in the community, and then that review was several weeks later. And I mention that because that has an impact on where we are now when I come to a later slide. So as I've mentioned, these were the key challenges. I won't go through them all, but as we moved through COVID, we then started to have to go, right, let's reevaluate what things are working well, what things are we going to keep, but actually what things can we no longer sustain. So we had to address some of these challenges. As I've mentioned, there were confusions around roles. We were suddenly overlapping, and sometimes we were better suited to complete some of those assessments, other times health were, but there was just a real confusion over who should be doing what, and we needed to iron that out. As Carrie mentioned, the reduction in funding and COVID, obviously we got a lot of funding come from government to support the discharge to assess model. As that ended, we were in a situation where we wanted to allow a model to carry on without financial support to sustain it. And that in itself produced a massive challenge for health and social care that we're still struggling with now, because ultimately to fund a very good model and to get it to work, there needs to be that ongoing funding. As mentioned, we were trying to improve how we get staff to feel more confident again and to rebuild their skills, because a lot of them did feel a little bit uncertain about what their purpose in the team was. And it was particularly hard for our new staff, the newly qualified staff. When I qualified, I was in an office, a hospital team over in Rochdale, and I had a wealth of stuff around me, the support I could learn from. Even if it wasn't something I was asking a question for, I could learn about other things, other cases, which prepared me, kind of equipped my toolbox better. Staff that were coming in newly qualified didn't have that luxury because their colleagues were working at home. We need to rebuild our links with health. There were some really strong links, and there still are some incredibly strong links with our hospitals, but there were also some barriers and a lack of understanding around some of the roles that we have to do. And I think, as Carrie mentioned, when we suddenly had to go back to the funding wasn't there, it was hard for the whole system to appreciate why we were changing things. And it was very much felt like the local authority was suddenly changing it, rather than actually the government funding ceased and we're in a different world now. We are getting better, I think, at supporting those individuals together. I think there are some times where people do struggle to feel like they're able to challenge one another, but I think we're getting more and more able to do that in a safe environment. And I agree that is a sign, like Carrie said, of a really strong system and team collectively. There were some tensions, as I've talked about, between stakeholders, and that's something that from senior management down to operational management and staff itself we've had to work on, and we continue to work on, in order to try and avoid that tendency to revert to our own disciplines and tendency to just go into our own areas and not work together, because it does impact on that integrated working. So we obviously, as I said, then what do we do now? And we needed to review the current model because it wasn't sustainable financially, and we were also letting people down unintentionally. So we had this discussion that we commonly refer to in our authorities as shift left, where we were trying to move people away from those long-term placement decisions in a hospital, which wasn't the best environment, and support them down a different route to try and hopefully get them back home or to a lower level of placement. Rather than nursing, could we support them to be in a residential home where they have a greater level of independence and control, but also financially that has an impact for them and both health and social care, as well as what's available for future individuals. If we overcommission, we then have a real problem of bottlenecking availability of care for the future discharges, and we need to avoid that. So we focused on reducing pathway 3s, which is the long-term placements from hospitals, unless it's an absolutely exceptional situation. During COVID, that was kind of the easy route, and for that reason, more people were placed than needed to be. And we're looking at trying to increase, and we're working on that quite well with both our partners in the hospital, but also our universal services and voluntary agencies around pathway zeros, people that can return home either with no support or with their existing support, and maybe some temporary universal services rather than commissioned care, and also around more P1s, which is the pathways going back home with increased support or new support for the first time. To support that, we've needed to look at widening our pathway 2 offer. So predominantly during COVID, that was for rehab and further health assessments only, and we've widened that to try as far as possible to include a recovery or further assessment in general, so that we can assess people in the right environment. Because we are limited that once we complete a Care Act assessment around charges and what services come in without setting up 2 different systems and creating equity across the local authority. It has its challenges, as you'll see on my slide, around having enough capacity. But without the right capacity, we are limited with what the options are, and we end up overcommissioning because there are no better options. So that's a real challenge that as a system we're working hard to try and address. To support it, we're also looking at a greater offer from a P1, and it's trying to move away from it having to just be the standard, often referred to as 4 care calls a day. You know, is there a different option that needs to be considered? Do we need something a bit more creatively? And that's something we're looking at moving forward. Sadly, we have had to move towards more of an increase into an assess to discharge model. And I say sadly because I do think that the best models are where we can support people to be discharged first and assess them in the right environment. But ultimately, when charges are coming in and when there's an implication that hits the Care Act and criteria where charges apply, we have to make sure that we've determined eligibility, and also support the individuals from being funded correctly, because otherwise we create a real challenge across the public as to why people get things free and don't. And that in itself led to a lot of complaints. I missed the complaint discussion that was going on, but there's been so much confusion at times with the discharge to assess model because we've had to evolve it as we've gone along, but we've had complaints due to sometimes misunderstandings from families, but also sometimes due to actually our staff being quite confused on what's our current offer, because it has had to move quite quickly. So the positives, we are evolving and we are getting clearer boundaries on this is the roles that health will do, this is the roles that social care will do, this is where our universal services can support and voluntary agencies. We are still needing to discuss that, and we are open discussions around that to try and support it. We are more integrated around TOCs, but we're not based on site. I mean, I think have quite big teams from what Carrie was saying as well. We've got nearly just over 40 full-time equivalent social care staff linked in with the hospital teams, plus operational managers on top of that. We're on site duty, and we're on site when we need to complete our assessments, but we're not solely based in a hospital anymore. And that is partly due to the fact we have so much work elsewhere, and our work, we're now more hybrid, but also due to the demands changing and the fact that we had moved to this discharge to assess model, and it's very difficult to get the balance. One thing that's made that working off-site easier is we have a shared discharge system in one hospital that we're looking to adapt in another hospital, which becomes almost like a live communication system so that we can access records, and we can also, like a running record, add a note on a question, and that can be answered by whichever side of the system needs to, without the need to make all those calls or send off emails. With it being a live system, we can make this confirmed or what agency it is and things like that. So it really helped to create like a thread through the system, which is incredibly helpful. We've also got very strong connections within wider parts of we're linked into this for sourcing care. We have voluntary agencies like Red Cross and Care Connectors involved. We have various other stakeholders that all together with help produce a system that allows many people to be supported in the best way possible. And we are getting a more inclusive offer, as I've said, around discharge to assess, to reduce that assessed discharge need, but we're not there yet. And I think it would be unrealistic for me to say that will be happening in the near future. We're really committed to trying to work out how we do this collectively with the limits that we've got. So as Carrie's touched on, there are so many roles that we have to do as social workers, and I think often that can be forgotten when you're in a rushed acute setting or discharged to assess P2 bed, because actually the key focus is we finish that part of their health need. Now we need to support that person to be moved on in order for the next person to occupy what is an essentially valuable bed, not just from a cost, but also for that person to get the right treatment and rehab. And that in itself creates dilemmas and real challenges for social workers. We're very committed to supporting people to be wherever their next step is, their home, the place they call home. But there are so many things that we need to do in order to ensure it is the right decision, it is equitable, it is fair, that we're not commissioning too much and leaving people to become dependent. So these are some of the key things that I've touched on that we do. Apologies, because you're probably more than aware of most of them. So obviously we support timely discharges from both our hospitals and D2A settings. We ensure we work within the legislative framework, whether that be the key one that we always use around the Care Act or the Mental Capacity Act, the Human Rights Act. There's so many bits that we need to make sure we're factoring in. And I think sometimes that can be seen a little bit as a hurdle and a barrier to supporting someone's discharge, but there is a requirement for us to do so. We obviously have our own policies and procedures within the local authority, and this can vary between the authorities, which I think adds an extra complication on when we're supporting out of area hospitals, and that will go for all authorities. There are different offers and slightly different approaches, whilst the eligibility criteria remains the same. What that support is around it can vary. We obviously consider mental capacity assessments and best interest decisions, making sure the LPAs are registered, that there's not any advanced preferences, and that's becoming an increasing challenge, because not only have we got more people that have brilliantly arranged an LPA, we're getting more people thinking about what their advanced preferences are, which is leading to some Section 21A challenges needing to be considered at a far earlier stage, which is absolutely essential from a legislative point of view, but a real challenge to the system. And it can often be found out quite late in the journey, which then creates frustration around why we're finding it out there and then. Obviously, we look at far more than just what's going on in the hospital setting. It's that triangulation of information in order to really make sure the decisions we're making are proportionate, they are correct, and they are in the person's best interest, and helping that individual to make informed decisions whether they're able to, or to advocate on their behalf when they're no longer able to make those decisions. We obviously refer on to advocacy. There's a lot of questioning and challenging of decisions, not to be difficult, but in order to make sure we get this right, because once we commission something and we discharge people, it's very hard to then alter that decision, even though we will do so where we can. If people are in a care home and you're suddenly saying now you're going back home, people get worried, or families can get worried, and there's going to be a long stage. We attend multiple MDTs, care planning meetings, discharge planning meetings, and there's a need for us to reflect on whether we can reduce some of those, whether we can be more effective together across health and social care to support a more slick system. We'll consider carers and their carers assessments. We lead on safeguarding inquiries. We support the 21A challenges that I've mentioned, or other court protection issues. And then a big part is also things that are sometimes not seen on an assessment around that managing expectations, the being fair, the being able to consider what is sustainable and consider things such as emergency support for their pets or their properties, things that we have a duty to make sure is in place, but not an essential role from a hospital discharge perspective, but really key at taking time when they're admitted that takes us away from the discharge end of a journey. It's difficult to decide whether we become better at identifying things such as hoarding and complex self-neglect, or whether this is a more challenging situation since COVID. It's probably a combination of both, but that's something that's taken a lot more time to support. And I'll come back to the comment I made earlier around when we move off the discharge to assess, all of our assessments move, and we started to assess when people were in the community or P2 beds and then reviewed. That hasn't changed, but on top of that, we're now supporting assess the discharge. So we have a lot more work to do with the same resources, which obviously is a challenge we're trying to work around and talk about how where one part of the journey ends and where the next part picks it up. And as Carrie said, that maximising that strengths-based approach is key throughout it all. Trying to make sure the individual is able to, without support, identify what they can do, and then what bits actually do we need to commission support for, rather than that automatic putting in a 4 care calls or arranging a placement. It's not been an easy journey, and there have been things that we've had to try and do to help strengthen the social work role, of which there's a list of them on here, and how we try and do that. And a real big part for me is how we continually have open discussions around those challenges, around where things aren't right or where we need to make improvements in order to support staff and health together for that person. Because there is a tendency, especially when there are pressures within the hospital setting, for us to come under more question and scrutiny, which I think absolutely accept and is right to do so. But that in itself can have a real detrimental impact on our professionals and in turn the individuals that we support. And so it's how we manage that. And some of the things we have done is establishing stronger, more supportive escalation meetings and steps where senior managers come onto the calls and we discuss hurdles where we're having difficulties on what pathway maybe someone should go under, or whether things aren't progressing, rather than that being a constant challenge towards the operational staff and managers, because that can be very disheartening and also impact on relationships and cause a damage that we don't want to be there. We've embedded essential meetings. You know, there have been lots of meetings. We've had to question whether we need all of those, and where we do, making sure they are part of a routine system rather than ad hoc where possible. A big part for us as social work has been about us having to remember what our roles are in this. This was blurred without a doubt during COVID, and we, like health, had to pick up everything and just support whatever we could to make sure we support individuals, and as many of them outside of hospital. But now we need to get back to making sure we're not losing our roots, we're not losing what our purpose is in terms of assessing individuals' views, assessing what they need and helping them to have what they really require and want out of this. Sometimes their voice can be lost and it becomes about the family or the ward or whoever it is saying you need 4 care calls, you need the placement. And as Carrie said, there is, I think, actually commissioning care isn't necessarily a complex bit, but it's all the wider bits that we have to assess in order to consider what do they really need, what else is out there, rather than creating that dependency. Because when we do, as I've mentioned earlier, we then actually create further headaches for ourselves in terms of not only the impact of the individual, but also the impact of the financial system, because it has an impact on health and social care, but also what is available, which then impacts on future discharges. And we're getting better at supporting those individuals for longer. So we need to really be mindful of our resources and how we ensure that goes to the right people. That's a really kind of quick feeding. I'm conscious I've probably spoke at 1,000,000 miles an hour. Apologies. Talk of what we do.
You're bang on time, actually, Sarah. So thank you for that. It was brilliant. Loads of stuff going on in the chat, which we haven't got time to pick up yet, but we no doubt we'll be able to do that when we do this sort of panel session. We'll pick some of the issues out and sort of ask some specific questions for you on that. But thank you so much for that. So I'm going to move on now to our colleagues from the Northern Care Alliance, Jack and Daniel. So do you want us to share screen? Or oh, right, great, brilliant. Over to you guys.
Helen, is my sound okay now? Do I sound okay?
Yeah, it's fine. Yeah,
Brilliant.
I can hear you.
Brilliant. Thank you very much. So thanks for inviting us today to share some of the work we've done. I can see a number of colleagues who may have been involved with Collaborative on the chat box as well. So great to see a few people on there. So my name is Daniel Robotham. I'm in the Quality Improvement Team Northern Care Alliance. I'm going to share the work we've done on the Days Kept Away from Home Collaborative. We're in 2 phases. We've started from a collaborative, which was a number of pilot wards, and then since about November 2024, we've been working on sharing a change package. So just to give you the background, the Northern Care Alliance, you can see the 4 localities that are covered there with hospitals in each site, so Salford, Bury, Rochdale and Oldham, with the A&Es in Bury, Oldham and Salford. For the collaborative, we picked 18 wards that were going to be pilots that are working with us as part of the collaborative, with 6 wards from Salford, Bury and Oldham, and these trying to invite the integrated discharge team to be part of that collaborative as well. And that was the starting point for us. You can see the stakeholder map, because of the size of the footprint and the who we would cover. There's quite a lot of stakeholders that are involved, so there's a lot of engagement work needed to sort of share this work and build this up. Next slide, please, Chap. So the origins of the work. So I think there was probably a couple of things going on. This was around about December 2022. We could see that sort of from an in-hospital perspective, Our admissions probably weren't as high as they were pre-COVID. Our attendances weren't sort of hitting the same heights as they were pre-COVID, but what had increased was the sort of the time spent in A&E. So we're seeing patients staying for prolonged periods in A&E, even though there weren't more patients coming into the departments typically at that point. And so that sort of pointed us in terms of, from a ward perspective, there must be a bottleneck, and we weren't getting the patients to the beds that needed the beds. But probably the stronger driver was sort of conversations with social care colleagues. So Adrian Crook, the Director of Adult Social Care at Bury, sort of was involved throughout the collaborative and has been a fantastic sort of leader within this space to sort of help us drive this work and educate our colleagues. But I think from Adrian's point of view, he told us that sort of since the pandemic, demand on social care, he had doubled the capacity within Bury in terms of the social care for patients who were being discharged from hospital. But in order to meet the demand that was actually being put at this point, he would have had to treble the capacity, and there just wasn't that capacity anymore. And that was sort of obviously leading to patients being in hospital beds for longer, and actually sort of putting a sort of an unmeetable demand on adult social care colleagues in Bury. But we also sort of started to understand the opportunity of actually looking at this particular piece of work, because 40% of the package of the care that were being prescribed from in hospital were cancelled within 48 hours. So not only when we were requesting adult social care from a hospital perspective, we couldn't meet the demand that was being requested, but actually 40% of what we saw just for the packages of care was probably inappropriate anyway. So there was an opportunity for this piece of work to really look at actually reducing the demand in a safe way. And probably the other sort of key driver, so behind the hospital beds across in lots of the hospitals, we have a sort of a patient information board, and on that patient information board we ask the patient what matters most to me today. And if you go around all the wards now, and most of the wards now, the overriding message that comes back from patients in inpatient wards is, I want to go home. So actually getting home is the key thing, and it just makes sense. And actually, I think what we also found in this space, and I'll come to it in language, is actually this is a key driver for the clinicians as well. So, and I think Carrie's touched on it in her presentation, which we'll come to. Now, this is sort of what I'm going to highlight some of the ways that Adrian really helped us. I think we didn't have to bring this data out, but this data sort of showed the life expectancy of care residents from the Office of National Statistics. But what Adrian did was sort of really help sort of from the hospital perspective to understand the social care perspective, which wasn't always well understood. And the first thing he did was stand up on stage and say, can everyone in this room put your hands up if you're looking forward to being in a care home when you're older? And you can imagine the number of hands that went up at that point in the room was quite illuminating. And sort of Adrian then saying, well, that's the same case for the patients that are on our wards at the moment. And actually the need to be into a care home is usually a life-changing event, and too often the life-changing event is an admission in hospital. So Adrian started to bring that perspective. He also brought this perspective of the process for booking sort of the packages of care and looking across the rotors to try and find 4 packages of care, and the impact that we could have on the wards just by reducing the number of packages of care per day. So Adrian helped us create that sort of burning platform for actually this is a really important piece of work. Our patients want to go home and they don't want to go into care homes. We want to get patients out of hospital as soon as possible and into the right place, and sort of create that will to do something about the problem that we had. We then started to develop what actually we're going to do about this. Well, now we had that will. You can see our aim of this on the left-hand side there, and we have to use usual place of residence, but what we really wanted to say was 95% of patients over the age of 65 to be discharged home. From a QI point of view, we've not always used this as a measure, because we've always been sort of 90% in terms of the patients going home, but actually having an impact in this space would be really, really important and really powerful. We looked at our sort of the areas we wanted to work, and what we weren't as good at in terms of social care colleagues with our strength-based approach. We were sort of seeing sort of anecdotally cases where patients were saying, well, we're actually saying, no, I don't want someone to come round, I'm fine. And actually also saying, no, actually you need someone to come round, make sure you've got that medication, make sure you, and sort of those conversations, because we were using that deficit-based approach and not using the strength-based approach. So actually educating our colleagues on strength-based approach and using that was one of the key drivers. Looking at sort of the deconditioning from a hospital perspective, we've done deconditioning before a little bit. We sort of had the NPJ paralysis campaign that was about around about in the 2017-18. But I think what we found was that the pandemic had forced people back into the beds and not getting out of bed as reliably. So it was an important piece of work to bring back as well. And then the really sort of powerful thing was where we saw some success on in the initial wards that picked this up was the discharge pathways. I think lots of our systems were well versed in actually, once you've been allocated a pathway, driving you through that pathway and sort of saying, right, okay, you need intermediate care, so we're chasing you down an intermediate care bed every day and trying to find that sort of that placement for you. I guess what we hadn't quite done is actually sort of started pushing down those pathways. We didn't do that as well. We did it in parts, but we weren't sort of doing it reliably. And so actually these three things and bringing these three things together were what we were going to do to try and get more patients back to home or their usual place of residence. Next one, please, Jack. I won't dwell too long on these, but for people who are sort of interested from a QI perspective, we used the Institute of Healthcare Improvement from Boston, their Breakthrough Series collaborative model. But what that meant, we would have 3 learning sessions and a summit where we would bring all those 18 wards together. We would do a bit of QI education. We'd actually think about what things we could do. We would agree what we were going to do next, and then we'd have action periods where people would be using those plan, do, study, act cycles to. Oh, I'm gone there, Jack. Using them cycles to sort of test some of the ideas out and drive them, and then come back at learning session 2 and share. Next one, please, Jack. We used an A3 framework, and again, the wards engaged really well with this. But what this also meant was that at each point, the wards had a sort of a record of what they'd done, so they could share the posters easily with each other, and that meant we could share ideas quickly. But also, what this had an added bonus as well in terms of, because the wards were getting some QI methodology here, we were able to accredit a number of our sort of colleagues in terms of the QI. So it was an added bonus in terms of giving them a qualification as part of this from a QI perspective. We also, again, this is just a bit of a more background. We used MS Teams. We'd never done this before, but each ward that was part of the collaborative had its own space in MS Teams where they would sort of put their tested change, but we also shared with them their data. So it was using their data regularly and using this statistical process control charts to track their progress, track the impact of the things that we're trying, and see if something was working or it wasn't. And it also gave them that QI sort of methodology and measurement understanding. So what did it mean? So again, in this place, we for the collaborative, we ran this from April 2023 to November 2023, and on the collaborative wards, we saw a percentage shift, and it seems like a small percentage shift there, but that impacted 84 patients during this pilot period, and it gave us a bit of an understanding that actually using this approach and using these ways could actually start to see more patients get home. And what that meant on the next slide is that the length to stay on the wards, and you would expect that to follow. I think we know that when we've got patients in hospital beds and they're waiting for something outside of the hospital, that it causes a delay to their sort of the discharge. So if we actually getting more patients home and not having to not putting an unmeetable demand on social care, we're actually seeing the length of stay come down for patients on those wards. So what did we do with that? So Jack, next, I think this is a feedback from Adrian. So I feel like I've done a lot of PR for Adrian on this call, but he has been absolutely fantastic in this space, and leadership has been a really important part of the work. But you can see sort of Adrian was with us with each of those learning sessions and listening to the wards feedback and giving the perspective of adult social care. But he was also sort of cheering us on as well with this. He would give us that done, but also he could see the impact that we could potentially have with this piece of work, and he was proud to say it was one of the best piece of work he'd seen in the 30 years of being part of QI projects and being part of sort of hospital discharge projects. I'm going to hand it over to Jack in a minute because I've rambled on for a little bit, but you can see there we had a lot of key learning outcomes for this, and Carrie's kind of touched on it with one of the measures there. Our clinicians didn't sort of study to sort of be a doctor or get a nurse or a therapist to then achieve the 4-hour target or improve our length of stay. They did it because they wanted to sort of help patients and help people. And I think lots of our measures in this space are measuring processes and not actually the person centric in this. And so I've worked on different pieces of flow work for a long time, and it's always been 4 hours, 12 hours length of stay. But actually, we shifted it here and actually looked at actual patients getting home and brought the person back into that measure, and it was the thing that our patients wanted. So it engaged our colleagues a lot better than we have done previously with this. With the language change, language is massive. Again, I'm always open to be educated as well with this. So if there's any language that we use today, please feed back to us, because we want to make sure that we're always conscious of the language. But there are no criteria to reside that we've typically used in hospital. We've tried to move away from that because it's felt felt like that's blaming a patient, like you've got no reason to be here. And actually moving that to the days kept away from home, actually you're not going, you should be home and we're keeping you away from home at the minute. And that's been sort of the language we've tried to use in that space. And obviously we love an acronym, so turning it into DCAF is a really catchy acronym for us there with that one as well. Breaking down the healthcare, the social care blame, I think that was again a key role that Adrian played with that. I think there's a tendency always, I think, when something's not delivering as you want it to try and point elsewhere to see where the problem is. And actually thinking of this, if we're asking for 40% of the ask that we're asking for adult social care isn't appropriate, then we can't be really pointing fingers elsewhere. It's actually owning the problem and starting to work on it together. I think that's a real key thing that Adrian helped us with, and I think we really saw it throughout the collaborative, looking at what we can do in terms of the discharge and that changing that working environment. So that I think it was giving a bit of that time back. I think everyone's really busy, and I can't tell you the amount of meetings to improve patient flow that have been cancelled because flow is bad within the hospital. And it's that actually, how do we protect that time? Because it's important that we sort of give colleagues the opportunity to be able to work on this. Now, Jack's going to go into the space where he's going to talk about the change package, because the work from the pilot ward has been rolled across the rest of the hospitals, and we're in the process of rolling that out right now.
Yeah, perfect. Thanks, Danny. So obviously, Danny's touched a lot on the first kind of 9 months of the project that ended at the back end of 2023, but we're now in April 25. So it's kind of what have we done since in seeing those improvements. One of the main things was off the back of the collaborative, we created a change package. This is essentially an amalgamation of all the best change ideas, all the top tips, all the kind of what you should do in this situation, who needs to be involved, and what benefits you can expect if you were to actually implement the changes that the wards themselves did. One of the biggest things that came out of the change package, and it is almost our logo now going forward, and it was created by one of the wards, is on the top right, is our days kept away from home triangle. And that's mainly around the biggest learning point of the whole process, of that all 3 elements, even though we started them off with 3 separate drivers, is that they're all actually completely dependent on one another. You need a good, solid, strength-based conversation to get to know the person, how they were before they came in, to help them with their re-ablement, for them to recondition better. And if you do that, that will actually drive the discharge pathway down. So not just focusing on one of the 3 elements, but all 3 of them being interlinked. And like I say, that was actually designed by one of our wards within the collaborative, and is kind of our logo now going forward. Within the rollout, we broke it up into 3 kind of key steps. One is bronze, and that's kind of it. That's probably been our most tricky part of the rollout. That was all around the learning, the understanding, the training. So people actually having the strength-based conversations, training, making sure everyone's got a discharge pathway assigned, and making sure that people, as a minimum, are just up and out of bed and engaged and ready for the day. Moving into silver, which was kind of the really exciting bit, the doing of it. So making sure that people are having a strength-based conversation within 24 hours of admission onto any ward, making sure that patients are actually engaging in cognitive and physical activities if they're able to, now that they're up and out, and making sure that every day, now that everyone has got a discharge pathway, that the whole MDT are actually challenging that discharge pathway every single day, making sure that we are driving down those pathways and not just kind of trying to go ahead on the one that has been assigned on them in the first place. And then gold essentially is a culture change. It's that days kept away from home is business as usual. It's the way that we do things around here. And the way that we measured that was actually for the wards bringing their days kept away from home patient stories rather than looking at the data. Because if the idea was that if every ward could give us 2 patient stories around patients that went back home that wasn't intended to in the first place because of the days kept away from home drivers, again, focusing on the patients even more so rather than your traditional processes, that will mean that your percentage of patients being discharged back to their usual place of residence will fly up another level. So again, the further we went into this process, the more we focused on the people rather than the processes. And that was kind of the key thing throughout. One of the really exciting bits, and particularly linked to this kind of masterclass today, was that we've actually created a strength-based conversations training package, which is available to all of our staff within the Northern Care Alliance. And within Bronze, the expectation for your ward to met the criteria is that everyone who is patient facing was to have done that ESR training. It takes around 10-15 minutes. Feedback's been really good on it. And that was actually designed by people within the QI team, people who set up the training packages, but also the wards that were involved in the collaborative. So none of this has come from ourselves. This has come from the people who do the work, know the work, and have those correct conversations day in, day out. And I think a social care worker was actually very, very key within this space and one of the key drivers of getting this set up. So everyone now who's been through the rollout, if you ask them what is a strength-based conversation, they should all roughly tell you the exact same thing. So we're all talking about the same thing when we're talking about strength-based discussions. Feedback is something that we've collected throughout. It's not just been kind of staff. We've constantly collected the patient feedback throughout. And as I said, within Gold, that is our main driver for the rollout. It's all about getting those patient stories of people that have made it back home that may not have done previously because of this work. Just wanted to show one of our biggest success stories, and this was Ward 24 from Bury. They've actually created a YouTube video that talks about their days care from home experience, the impact on the patients, the impact on the staff, the impact that quality improvement has had on empowering them. But the main impacts is on that right-hand side in the results. So throughout the collaborative, 30% of their patients that went through their ward were actually had pathway reductions from what they originally were admitted onto the ward because of the strength-based conversations, because of the reconditioning, because of that discharge pathway challenge. And you can actually see that in 2 cases on the ward, that people were admitted onto the ward to go on a pathway 3, so going to residential or care home, and actually within the admission onto that ward, we managed to get discharged back home with no packages of care whatsoever. So how really having kind of life-changing impacts on people who just driving that pathways. And did you see a massive area to focus on, which might be use, and what we have done within is focusing on that drive from pathway 2s down to pathway 1s. That seems to be a really big win across a lot of the wards to focus attention on when looking at reductions in discharge pathways for patients. So within the rollout, we staged this at 1 month at a time, as I mentioned, within the Bronze, Silver and Gold, and had a smart aim for each of the wards every single month, focusing on strength-based conversations, discharge pathways, and then reconditioning and making that a little bit more challenging. But it was so that everyone can come together within kind of a format of meetings, as it says, the monthly forums, the divisional forums, and the support forums, where the wards would all come together, share their evidence, kind of present to one another, share the learning, and kind of go through the rollout together. And as I mentioned, we have actually recently or coming up to finishing the rollout within our first care organisation within Salford. But what's the data telling us? So originally, when we first started, our current percentages of over 65s going back to their usual place of residence was 81% across all of our wards. At the end of the collaborative, so including those first 18 wards, that jumped up to 84%. And now since the rollout, we have jumped up again and had another shift within our data and maintained that, and are looking at 85% of over 65s going back to their usual place of residence. So we have jumped up another notch again since our rollout. This isn't just the case within over 65s. We then correlated that with patients of all ages. So we've gone from just under 90% to now up around 92%. All patients going back to their usual place of residence within the Northern Care Alliance. And then when we correlate that by, well, if a high percentage is going, what does that actually mean for the number of patients that are going back to their usual place of residence? So before we were looking just under 70% 7,000. Now within our past couple of months, we're up around the 9,000 mark because we've now spread this out across every single ward within the Northern Care Alliance. So it really is having impacts on thousands of people's lives. We have been doing our best to try and share this as wide as possible. So coming to events like this, part of the NHS England Discharge Integration Frontrunner program, we have set up YouTube videos that kind of explains what Days Kept Away from Home in a nutshell is, where to find our resources. And now other trusts within the Northwest are actually rolling out Days Kept Away from Home. So Liverpool are coming towards the end of their collaborative. We were just on a call with Lancashire Teaching Hospital the other day where they're starting their journey. We were fortunate enough to pick up a few HSJ awards along the way, which was really nice for the wards to get the recognition that they deserved. And that kind of wraps everything up. So going from the first learning session in the top corner to where we are today, and although it's not included in the slides that have been shared, because it was only last week, we had our first celebration event at Salford, and these are the first 6 wards that have actually achieved gold within the Days Kept Away from Home rollout. So they were up on the stage in front of everyone, sharing their patient stories, telling their Days Kept Away from Home journey. And we're going to have kind of over the next few months at the different care organisations, this is going to be replicated and kind of hear all of the patients' lives that have been impacted by this Days Kept Away from Home work. Thanks, everyone.
Thanks, Jack. Thanks, Daniel. Absolutely brilliant. Really great to hear about what you've been doing, and it was great that you name checked Adrian, who is a friend of Northwest and leads for us on our strategic performance network. So he's a real data geek, is Adrian. So it's great that he's also showing huge leadership in giving his insights as well over the last 30 years in adult social care. So it's brilliant, really great. So we have actually run out of time, so we can't take questions directly to you, but we are going to go out into some small breakout groups for people to reflect on the 3 presentations that have been delivered today. So thanks for all the presenters so far, but we are going to come back in about 20 minutes time, and really what we're asking people to do in the breakout areas is reflect on what has been discussed through the presentations, maybe give us some insights about your own locality or your own organisation and what's happening there, and then think about what you could ask the panel, because we're going to have a panel discussion about 11:10. So some questions for panel. So I've noted all the sort of comments and questions that are in the chat, so we'll try and pick some of those themes up in the questions. So I think, Christine, are you going to do the magic of getting people into small groups?
Isha's on the special button, so it will happen.
Yeah.
Imminently.
Okay.
Everyone's just moving now.
Thanks, Isha.
Room. Everyone back? Can I just check? Okay, colleagues, I think everyone's come back into the main room. I hope you had some really great discussions in your breakouts. So we've got a panel with the presenters that have given us the 3 presentations this morning. So be really good. I hope there's somebody really brave who's going to give us some reflections of the discussion in their group, and then maybe ask a question to panel. So who's brave enough to put the hand up to do the first reflections from their breakout discussion? Got no hands going up. Oh, excellent. Is it Claire first? Oh, let me get me. So is it Claire? Claire, can I bring you in?
Yes.
Thank you. Thank you for being so brave.
All right, I wouldn't say brave. I don't mind talking. So I'm Claire. I'm Deputy Q at Pennine. So I've only moved over to mental health 3 months ago. My background is acute, so I worked at Wigan Acute for 15 years. So one of my kind of culture shocks is the lack of parity between mental health patients and physical health patients. I think the two presentations kind of, whilst both brilliant, kind of were actually coming from quite different angles. And what we're not great at sometimes within the NHS and wider healthcare is coming up with the least worst option instead of the ideal. So, you know, the social care presentation at the beginning, thank you, Carrie, that was kind of very focused on the individual patient and advocating for the individual patient, which is really, really important. But actually, we've got lots and lots of patients waiting who are often at more risk than the patients who are already in the beds. So there's that kind of MDT decision making needed to agree at the least worst option to manage all of our patients rather than the individual, which then is kind of where the NCA presentation kind of picked up. So I was kind of interested not just in the lack of parity with mental health, because I have the same DAS and a very different response. So that's kind of across the board, across all localities. There's a very different setup for kind of managing CRFD, managing some of these things. So that was why I was asking, could we meet up maybe with the NCA team, because we're serving the same localities, we're serving the same cohort of patients and giving them a really different offer. So if a patient was in a physical health bed 1 week, they would be discharged with a certain package of care within a certain amount of time. If the same patient happened to have a mental health condition and required admission, they'd probably sit there waiting about 6 months for the same package. So I think there's
really
probably
good.
a lot we
Yeah.
can do
Yeah.
across localities to learn from the days away from home.
So I'm sure Jack and Daniel will take you up on that offer, but I'm just wondering if there is any comments back to you about the points that you've made from panel members. So I don't know if Sarah, you want to come back in, or Carrie come back in. The issue of mental health came up quite a bit in the chat as well, so I'm glad you've raised that about the parity.
So I mean, we do have some challenges without a doubt when it's an individual whose primary need is around mental health. We are, if they're in the acute hospital, we do support them in the same way. If they're not, if they're under a section and things like that, we do have a slightly different route and more complicated system. I'm just going to say in some ways when it is around whether their physical or their mental health needs are outweighing. In the hospital, we seem to be working through that. I'm going to say more on an individual basis rather than it being we all know what we're clearly doing. It's normally a discussion between my level and another level to make sure we don't get that wrong. We do struggle with input from mental health outreach when it's one of our patients or individuals in a P2 bed in one of the rehab and recovery beds. We don't always get the support that we need from the community mental health team, and that is a real gap that we're still trying to work on because they're temporary rather than permanently registered in our P2 beds. That creates quite a few challenges and headaches that we haven't overcome fully yet. We, again, on an individual basis, end up having quite a lot of high level discussions and finding a solution at that time for that individual. Definitely a gap that we still need to improve on.
Thanks so much. Thanks for that point as well. Tina, can I bring you in? You've got your hand up.
Yeah. When I was sat here listening to Daniel, one of the things I've personally been harping on about for a long time now, especially since COVID, is the NPJ paralysis. I think, as everybody knows, years ago, there used to be day rooms, or there used to be some sort of room on a ward where people, I know at one hospital I used to work years ago, they used to get the actual patients to go to a food cart, collect the food, and then go to a little room and all eat together. Obviously, the only ones that could physically do that. And I really don't think we had the same throughput of services that we do now, whereas a lot of people will go on the wards and we'll see that they've been in a bed from admission. But obviously there's a lot of pressure on ward staff, not enough ward staff, which is causing a lot of issues. And I think also that managing expectations. So people are telling people in beds in hospitals, oh, you need this, you need a package of care, you need to go in a care home. It's free. So then obviously by the time they come to social care, we're then having to undo all them expectations when they're already, you know, they're in hospital because there's some sort of trauma happened. The family sometimes are not coping before they've come in hospital. So trying to reverse that can be very, very, very difficult. And I think what we're going to start doing is a bit like, well, obviously not as good as what you'd put on the screen, Daniel, but is a bit like educating not only our staff, but also ward staff that, you know, everything's got to be person-centered. People do have a choice and it can't be taken away just because of bed pressures. But we've obviously also got being mindful of bed pressures as well.
Tina, can I just ask where are you from? I should have said to everybody, could you just introduce yourself and where you're from, just so it gives a little bit of context for others on the call.
Rochdale Council.
Rochdale Council, right?
Yeah. Hospital Hub.
Hospital Hub. Daniel, is there anything else you want to pick up there?
No,
Coming in.
I think Tina, it's a fair point, because I think as much as I think we've still got work to do in terms of the strength-based conversations, and we keep on finding that one wrong conversation can undo the work. But we find this at the back end wards. We also find that what you're finding we might have a conversation early on in the patient's journey that says you need an intermediate care bed, and as well as trying to sort of get the patient so they don't need to go to an intermediate care bed, it's that we've set that expectation for the patients then, and it's quite often undoing that way. So it's something we see within the hospital as the patient moves through as well, that you'll see. But I also think the sort of getting the patients up and ready and things, I think it was all the wards went to that because of the NPJ work, and I think there is still some way for us to go, because I think COVID's made us try and stop patients wandering around the wards and keep the patients in bed, and it probably took us, them 2 steps forward probably went 3 steps back, and that's what where we're trying to push that. But yeah, it feels like a familiar thing that you're saying, that we're probably experiencing at some of our back end wards as well.
Jack, did you want to come in on that point, by the way? Sorry, I know you saw you put your hand up, or was it another point?
Yeah, no, it was kind of backing up what Danny said, and in agreement with Tina that when on the Friday, just last Friday, when the wards were presenting their kind of journey, and one of the final slides was, what are you going to do to sustain this work and embed this work and kind of keep it going forward? One thing all we pushed on is having a strength-based conversation with the patient. A couple of the wards that presented said they're now going to take it a step further, use that training that they've had and have the strength-based conversation with the family, friends, carers as well, and record that as part of their admission, just like they would with the patient, because a lot of the pushback that they're getting, even though the patient is happy with the plan, is because of this traumatic event that's happened. They don't feel like they can support the same. So actually taking it a step further than what we thought originally, and using that training with the family members, friends and carers as well, which is really interesting to see what happens with that as well. See if that has a big impact, hopefully.
Yeah. Carrie, did you want to come in there, or have you got a different?
Yeah, no, it was just to I think this links quite neatly with what I was saying about discharge to assess models, not just moving the issue further downstream, because one thing, and it came up in the chat, that I think, Tina, when you're talking about, they used to have day rooms and like getting patients up and about, getting meals, things like that, because people used to stay in hospital longer after they were, there was sort of a recuperation, rehabilitation part to a hospital stay. One of the things that really troubled some of my participants was that a lot of bed-based rehabilitation, it's not bespoke, it's within residential care, and therefore the staff don't necessarily have the training, they don't necessarily have the motivation. and probably most importantly, don't necessarily have the facilities to support people to continue that rehabilitation. So things that people pointed out was, well, you might go in because your mobility is not great and you need to have some support to work on safely getting showered and dressed of a morning. But if you've not cooked your meals, even made yourself a sandwich and a cup of tea, you've not been allowed to deal with your own medication, you lose those skills as well. So actually, quite a few of my participants were worried that rehabilitation had the potential to make some people more dependent. So yeah, I just thought that links in neatly with that point.
Thanks for that. It was great. So we've got somebody with Ed. Could you introduce yourself and ask your question? Ed, do you want to come in?
Yeah, morning. So I'm Ed Johnston from Blackburn Local Authority. And yeah, I think there were two main strands in our discussion. One was about the D2A side of things and where that's still pertinent as a model. And really chiming in with what Carrie was saying there, as to it feeling like a model that has opportunities to it, but there's so many parameters around the way that it's actually configured can really undercut that. And certainly that stuff about environment and setting and what's wrapped around D2A to make it actually a meaningful process in any way. Yeah, it feels really key. So that really chimes, really helpful. I think, but also I think in general, there's a lot of talk about the days kept away from home approach and a real envy, to be honest. Or I mean, the idea of actually having a kind of a full kind of almost like a sort of system, a full combined workforce buy-in to a strength-based home first approach feels such a good place to get to. So I suppose the question for me, and I don't know if there's anybody else on the panel who'd on our group who'd want to say anything different, would be it's kind of that how that conversation starts, really, because there's obviously something about buy-in. There's something about getting past a point where there's almost kind of a tug of war between competing priorities and actually getting to a point where you've got that as a shared priority. And yeah, I didn't know if there's anything that around getting to the sort of starting line for that.
Yeah, so I'll ask Daniel or Jack to come in on that, but it sounded to me as well, I think that leadership role from the Adrian as the DAS, and I think he obviously represented the other areas as well. That sounds like a critical thing, but I'll see if Jack or Daniel agree with me on that.
From me to start, Jack, I think in terms of how to get to the start line. So I think from our perspective, it was a lot of conversation to get to the point, but I think it's not, if we get the sort of the area of the work right, it's benefiting everyone. You know, we spend hours a week within hospital working on patient flow and increasing discharges. Patients want to go home, and we put an unmeetable demand on our social care colleagues in terms of what we're asking. So I think initially it was sitting down with some clinical colleagues from within the NCA, social care colleagues from mainly Adrian to start with from Bury, and a few sort of operational colleagues, and actually sitting and within there to actually go to board and say, this is our problem from a social care perspective. This is our problem from a hospital perspective. This is what our patients want. Like, we want to go and do this piece of work, and it was taking it to our board and getting the support for that. I think it wasn't just getting to the start line. It was a challenge though, Ed, from that perspective. In the sort of the hospital flow work, there's always a tendency not to see, because today's results were bad, the plan's wrong, so we need a new plan is a thing that tends to happen over and over again. So it was I think getting to the start line was reasonably easy because it was in everyone's interests, but actually sticking to the plan was then the challenge, because we didn't see results straight away, and flow's bad in hospital for a week, and actually say, well, that thing's not delivering, so what's the new plan? And it's actually sitting down with that. I think the other key part of it as well was from a reporting perspective, we fed into the 4 localities partnership, so it wasn't just when we reported back on the project, it wasn't within the NCA walls, it was within the 4 localities walls. And so that led to good communication within the localities as well, and understanding, and again gave us a bit more sort of space to protect this as the plan and not divert the work or divert the attention elsewhere. So they're probably the key bits I'd think about in terms of again learning and what went well, and I can give you a list of the things that didn't go well as well. So probably I won't take all the time up, but happy to catch up outside as well and have conversations.
Ed, do you want to come back at all? Are you happy with that response?
No, that's really helpful. I mean, I think, yeah, it would be interesting to hear some of that blow by blow of kind of what the kind of pitfalls are along the way. But yeah, appreciate the sort of constraints. And I think somebody's put in the chat just now as well, sort of seeing the slides, because there's a lot to take in. So if it's possible to share the slide decks from today, that'd be really helpful.
We'll definitely be doing that. Thanks so much for your question and your reflections. Anita, can I bring you in?
Yeah, sure. Hi. Yeah, the group we were in, I'm bearing in mind, folks, we had health and we had social care staff within our group, which was good. But I think what I picked up and what we spoke about, you know, from the presentations delivered about listening to the patients and the families and having that in-depth conversation from the outset, managing the expectations. But what I did learn in our group was Wirral. There's some colleagues from Wirral, and they have home first, which is different. And obviously, I'm from a health, not the social care setting. And when you're talking about obviously what's right for the patient, and I seem to pick up from the presentations about making sure the package, I think it came through across the board. It's quite easy to get the packages of care at home, more so than nursing placement, and that is my experience at the moment from health. But in terms of, they had home first, which is like a 6-week service, you know, with their own HCAs. So when the person's in the home setting, they can then identify what is actually needed and make sure that the right package of care is in place at the point it transfers over to a provider. So that was really interesting from me. And I don't know whether, because I'm from health side, whether any of the other people wanted to come in and add anything on, because I may, you know, that's just from my take. One of my other colleagues said, on the group, said they were interested in about PHB. Now, again, within my setting, I don't have much involvement with PHB. I know there was a big driver and a big push, but I'm kind of on the other side, the brokerage side, so I'm kind of excluded from that. I have a little awareness. Okay, thank you.
So I don't know, so PHB, so personal health budgets. I don't know if Sarah, what happens for Cheshire's around personal health budgets?
So we did have, I think, a much more positive approach with agreeing and being able to sign off PHBs up until about a year ago. Now it's very difficult unless it fits quite a strict criteria. So we're finding not many people are eligible, and it's not really supporting those quick discharges. It's so we originally house cleans and things like that, we could approve part of the funding coming from that and part coming from the person themselves, but that's all stopped now. So we're really restricted. We're not finding it as flexible really, which is impacting on discharges. It's a shame. And we do have, I think we have both, we have a mixture of approaches. We have a GNA service, which is like HCAs internally from health that support discharges for care at home, where it's further assessments or rehab. And then we have a different offering the other side, and you can see quite a difference when it's not being overseen by health around how we can be flexible around some of those quick wins to support people home where they haven't got the long-term needs. So that's where we're kind of evolving. We're trying to get consistency across the two hospitals. But yeah, PHBs, I don't know. I used to be one of the people who could authorise them as well, but that's becoming more difficult, unfortunately. I think everyone's budgets are just getting tighter and tighter, aren't they? And
yeah, is that the reason that it's becoming more difficult? Is the budgets, the constraint on budgets?
They've not said that, but it's become very much ring fenced against anything to do with cleans and things like that, which it means people end up in hospital in a much more expensive, costly bed. There's then a bit of a deflection on the local authorities on the we should pay, which obviously it doesn't fit our criteria either, but we do allow people to have the deep cleans arranged through us, but then we recover the cost of the individuals, so they need to understand it's at a cost to them. So it's another tension that has been created by, I think, just the general financial pressures across the whole system, not just social care.
Right, thanks for that. Mark, you've got your hand up. Do you want to come in? Where are you from, Mark? What do you do?
I'm
I'm Mark Hodge, sorry, I'm the social care lead for the mental health care division. I work for Mercy Care as a trust. No, it's just really interesting, them comments, because I think sometimes it's how you see a situation, isn't it? How you view it. Because if you're looking at budgets getting tighter and not having the same resources available to look at personal health budgets, and obviously the role that they can play in certain cases to support hospital discharge. But if you looked at it slightly differently and considered the fact of for each day that a person's in hospital once they're clinically ready for discharge, and how much that hospital bed is costing, a personal health budget to me is a lot cheaper than putting somebody in hospital. And that's completely outside of the fact that they shouldn't be in hospital. You know, we should be looking to discharge them because they are clinically ready for discharge and discharge appropriately. So when you're looking at costings and finances and funding, sometimes you just have to look at it from a different angle, in my opinion. And it's a bit difficult to, you kind of like have to form your argument, don't you, before you have the discussions about funding and then being able to evidence it with data and different things. But to me, it's a little short-sighted to say, well, we haven't got this money for personal health budgets when actually you're spending more money keeping people in hospital. It's just my opinion on it.
I absolutely agree with you, Mark, and it's a discussion we have on our escalation calls a lot, that the cost of what may be a £300 clean compared to those extra 5 days that the person has in hospital, not only the cost to the trust, but actually that person that maybe needed that critical cardiac bed or whatever ward they're on. I think the problem here, and I think it's a problem for health and social care as well, is those things are not all together. They're all separate areas, they're different streams. I think that's a real problem for health and social care too, that it's around, is it social care, is it health? And actually, when we come down to it, it doesn't really matter whether it's the health fund or the social care fund. It's the same person's needs, it's taxpayers' money, it's coming from ultimately the same pot. And yet we have all these debates of which route it goes down. And unless we have a really true pooled budget where it's a far more forward-thinking approach, I think we're going to keep going around to some of these challenges, because it does become against, is it them, is it us? And it's really disheartening for the staff as well as the individual.
It's sort of counterintuitive, isn't it? Because actually, if we're working in a strengths-based way, surely personal health budgets is the way forward. Carrie, did you want to, you had your hand up and put it down?
I did, because Sarah more or less said what I was going to say.
Yeah. Okay.
But to be honest, just to add to that, I think it's a problem across the entire system, and I think that's where I mentioned in my presentation, you know, there's some excellent work goes on at individual level and individual sort of relationships between health and social care, but at the end of the day, it's an artificial divide that causes a lot of work to try and understand these systems and budgets and arguments about whose responsibility it is, when actually, as you said, Sarah, it doesn't really matter. The end goal is the same.
Yeah. Thanks, Carrie. Jane, you've got your hand up. Who can you introduce yourself and where you're from as well in your questions or reflections?
Yeah, hi. So I'm based in Liverpool. So I'm part of the hospital in Liverpool. I work for Mercy Care, and obviously I manage our social work team here. First of all, as Carrie, sorry. First of all, as sorry. Oh, my fault. Sorry. No, it's not your fault. We have these so you can't hear them, but you can hear me. Sorry.
No, it's okay. It sounds like you're in a busy office.
Yeah, I had to get out of the room before. So what I was saying, from it's an individual in our team, we're fortunate. We have got really good MDT. Yeah. We value our consultants, our therapy, our nurses, and we do work well together. Very similar to the model, the strength and the silver, bronze, and gold.
Yeah,
that jackets. It's just not formally like that.
Yeah.
But we also use universal services as well. Utilize free shopping services, lots of things our advocacy they can support with as well. That
so
way
are you
we
using
can't
quite
access
a lot of third sector organisations
exactly.
to support?
So it's just about working together, using, you know, other universal services to help us. Obviously, we don't support with, you know, looking at shopping services as part of the care package or cleaner services, but we can signpost and refer because we do have universal services that can do that. So it's just about broadening your knowledge, working together as an MDT, and take the finances out the way. Because at the end of the day, if you do a full strength-based, needs-led assessment, you know, that's it.
Yeah. So I suppose
Which,
it'd be good to just get some input, wouldn't it, just from Cheshire East and Northern Care Alliance about their, I suppose, their universal offer and how they may weave in other services like the voluntary sector. So I don't know if Daniel or Jack, is there anything that you could input there, and then Sarah? All gone very quiet. Mark, are you going to respond to that, or is that a separate question from you?
Sorry, it's a separate question, but based
Right,
on the
okay.
general conversation that we've got, it's just to pass on some information.
That's fine. Sarah, is there anything Cheshire East do
So-
around weaving in sort of like a universal offer and use of the voluntary sector?
Yeah, so what we've got, I mean, there's been obviously a real push to try and help inform staff so they're more aware of what's out there, but obviously those offers do change quite quickly. So our care connectors are key. That we have LACs in the community, which are called local area coordinators, and then there's care connectors in the hospital settings who literally connect that person with the services they may need, that where it's not a commission service, not a chargeable service. So whether that be some shopping calls, or whether that be some informal visits or befriending, or just knowing what's out from a private point of view, they link in that to try and avoid or reduce those people that don't need to come into the formal care to try and reduce those pressures. That's been quite successful. We also have Red Cross support. They're commissioned to do so, and they will support with so many hours for the first couple of weeks. So there's quite a lot we've been to already progress with, hopefully as many P0s as we can, or where we need to P1s with the universal subsidies. So I think we're quite good at that, although we are needing to review some of the commission bits with some of our voluntary sectors to actually see, are we getting and delivering best value for money, or is there a better offer that we could have out there to support a greater number of people? But our care connectors are invaluable really with that, including just accessing the property and making sure things like the heating is on, or seeing if there really is a problem before we get into that discharge plan.
We've also got our social prescribing service as well. That links in with housing, or, you know, mental health, your local GP practices, so we can actually refer as well into those. I just think it's, as you say, it's about education, working together and being clear of what's out there. Don't build families or service users' expectations up. You know, from the get-go, don't talk about finances, because it's not just about meeting the needs, it's about meeting their safety and well-being as well. You know.
Thanks,
Yeah, no,
Jane.
I think
Thanks. Go on. Sorry, Sarah, do you want to come back in?
I was going to say, the thing we need to probably work on still is, I think you're absolutely right, we've got social prescribers, we have local area coordinators from local authority, we have the care connectors, and it's about making sure all of those are still up to date and providing the same information, because sometimes they can be aware of different things depending on where they are. So it's obviously the way we need to move forward, but it's some really good strengths-based approaches without needing to go through a commission service where you're making people dependent, and also then impacting on finances as well for them and organisations.
Thanks, Sarah. Mark, did you want to come in now?
Yes, it's just a thought really. That's something I'd like to share with Sarah. We're very much becoming involved with working very closely with Bradford and Craven. I was recently invited to an event that they held, and they came to a celebration of social work event as part of social work week recently. And the reason why I mention them is they've piloted for the last year one-off personal health budgets. And what they've been able to do is put a structure in place where they work very, very closely with an organisation called Mind, and they get budget, and Mind actually manage the budget. but they're looking as one-off personal health budgets to get the certain things in place to support. So it might be something within the home, meds cabinet or something like that, you know, a wall-mounted one, or it might be some form of technology that helps. And it's been very, very successful. They've just recently done a presentation to present data on their first year of implementing this, and they've been able to evidence that they've saved about £500,000 that they've been able to evidence based on bed days and stuff. But the reality is the savings is at least double that, because when you think about people preventing people from readmission, and you think about stopping people coming to A&E, they're kind of like, you can't put money or a value on that really, can you? But obviously as a resource, there's the hospital staff that are still managing them situations, particularly in A&E. So it's very, very successful, and linked to what we're hoping to develop within Merseycare and the Mental Health Care Division inpatients is Jackie Hooley, who works for Bradford and Craven, has very kindly agreed to work with us and support us and give us some information so that we can start exploring it ourselves. So from our side of things, from Merseycare's kind of things, we've had a couple of meetings. It's in its infancy. And I'm hoping to really use that model that they've created as part of their pilot, with the odd little change, because it does need little changes in different people's areas, doesn't it? But clearly it's successful, and it is reliant. So we've had no funding agreed from our side of things yet. So where this funding will come from, the one-off PHPs, but we've got a model, and we've got a model that we can actually demonstrate now clearly works. So when you're putting that argument about what we said earlier about, you know, the people being discharged appropriately and saving on the cost of, you know, bed days and all that kind of stuff, all that's included within the work that Bradford and Craven have done. So I'm speaking on behalf of Jackie Hooley. I don't know what her capacity is, and I hate introducing things when I haven't spoken to the person first, but I just thought it was really relevant to what we're talking about. And this is a model that is working and is saving a lot of money, but more importantly, doing the right thing for the people that we support. So if you want, Sarah, if you want to put your contact details in the chat, I can have a word with Jackie and see if she can contact you. If you think that would help in any way in relation to the work that you do.
Absolutely. I think it's always really helpful if we can, you know, find out what other people are doing and almost steal some of those ideas to try and help make improvements out. And Leonie might be keen to join as well, just because you help link in, don't you, with some of that, but your question might be unrelated. But yeah, I'll put my email address in. That'll be really, really helpful. I think health are very open to different things differently as well.
Yeah, no, I was just going to agree with you, Sarah. I think that would be definitely something that would fit within my portfolio. I think I've met a chappie over in Merseyside who runs the Spider project, so that would definitely be something that I would, like to get involved with, please. I'll put my contact.
If you put your contacts in, and then I'll contact Jackie and ask her to make contact with yourselves.
Thank you.
Thank you.
So I'm really glad you brought that up. I think about a year ago, it might be even 18 months ago, I think we did some kind of workshop or masterclass on personal health budgets, and we've still got all the presentations, I think, and it's from colleagues in the Northwest as well. So there's obviously pockets of really great practice in the Northwest where we are using personal health budgets in a really effective way, and a bit like you mentioned the costings. There was some great evidence from these presentations about the impact on costings as well, that we just spend a little bit of money here and it has a massive impact on reducing costings in the hospital system. So I need to go away and try and find all those presentations that we delivered a few years back, actually, and maybe we can revisit doing something about maybe direct payments and personal health budgets. So that would be really helpful. So I'm just conscious of time, colleagues. Is there any final questions before I start summarising and wrapping up? Okay, I can't see any hands going up, so it's great. So I just want to thank so much the presenters for today, which was Carrie, Sarah, and Daniel and Jack. Thanks so much for coming along. It was really, really insightful. Loads of things coming up for me around getting your relationships right with across your health and social care, getting the communication right, and respecting professional boundaries really, and understanding that we've all got something to sort of give in this space. So thanks so much for that. All the material, I think we've mentioned this throughout, is that we will be shared with you next week. There's loads of resources from this session. There's also loads of resources on the Northwest ADAS web pages as well. If you could spend just 1 minute, 2 minutes just doing an evaluation of this session and giving us some insights about what you might want to see in the future, that would be really great. There's a QR code here that leads you to, I think it takes 2 minutes to complete the evaluation. Really appreciate it if you can. If not, we will send that out with the pack later. And yeah, just to also mention, we've got another masterclass coming up on Thursday, the 24th of April. And it's outside in thinking, how innovative thinking can help the public sector. So that's, you know, we've got a guest speaker coming to that. So hopefully we might see you at the next session. Thanks everybody for your time, and I'm going to be around for a couple of minutes if you want to chat with me. Maybe some of the speakers could, but thank you so much for joining us on this session.